like to welcome Professor Amy Littorini to the stage to lead us in this storytelling, and she'll tell you about our guest who's joining us from a very exciting location today.
Hi, everyone. I'm so glad that you're all here, and I'm just absolutely thrilled to have Allie with us, Allison Yeagle from the Bahamas, with the Caribbean breezes in her hair. And Dr. Palladino is working to pull her slides off. But let me just tell you a little bit about Dr. Palladino. She is a breast cancer surgeon and has been treating breast cancer survivors for over 30 years, and I was privileged to be her breast cancer patient navigator for several years. We worked together at Exeter Hospital on the multidisciplinary breast cancer clinic. So I am just absolutely beyond ecstatic to have them here with us. And it's like, you know, it feels like the band's back together. I miss my Exeter crew a lot. So what I wanted to do was just sort of get us oriented to the plan for today. I have had the distinct pleasure of introducing some oncology concepts to the third-year students in the DPT program who are here, as well as the OT students who are here. And so for everyone who is here, we hope that you take away some great information. What I'm going to start with today is about cancer survivorship broadly, as it is in the United States, and then Dr. Palladino is going to speak specifically to breast cancer management. And then we have Allie here with us, as she has been for several years now, to talk about her, I feel very tall, to talk about her personal experience with breast cancer. So we want this to be an engaging interaction with you guys, so that obviously for her to be able to hear your questions, we'll probably have to do the little microphone pass. But it's going to be an amazing experience for everybody today. So let's go ahead and get started. I want to talk a little bit about cancer survivorship and just sort of put some context into today's discussion before we get started. And so essentially what a cancer survivor is, as far as the technical definition, and I bring this up because some survivors are reluctant to call themselves survivors until like a pivotal point, like a 5-year point, where they feel like it's like that at that moment it's okay for them to call themselves survivors. And that technically is not really how we look at it. A cancer survivor is a survivor from the day of diagnosis. And as I mentioned earlier, I had the honor of being with Dr. Palladino when she delivered the diagnosis to many breast cancer survivors. And so from that moment, that is the point where cancer survivorship begins. So, and it's through the balance of life. And something else to remember is that 16% of cancer survivors already have a history of cancer when they get a new diagnosis. So a lot of people, it's not just one cancer. And so when we think about survivorship in the United States, presently they estimate about 14 million cancer survivors. So this is a large patient population, and it's projected by 2020 to be 18 million. So while you all are practicing, this is going to be a large group of individuals who need your help. The estimated expenses, so if we think about things like the triple aim and making sure that we're delivering care in a cost-effective way, is $173 billion is the estimate for 2020. So when we think about the number of cancer survivors, and this has been due to technology improvements and other advancements, looking back in the 70s, the number of cancer survivors versus the projections for 2020 have risen consistently every single year. So think about while you're practicing. So think about your early career, and those numbers are just going to continue to rise. So when we look at the numbers are one thing, but the duration of survivorship is another. And so one of the other things that we've been very good at doing over the years, due to improvements in technology, is the length of survivorship. So if you look back in the 70s, it was not at all entirely common for people to have long-term survivorship. So if you look at the purple bar or the blue bar, we're talking 10 to 15 years or greater than 15 years of survivorship. Versus the projections for 2022, we're looking at people who are living with a history of cancer much longer than ever before. So that is great, but we have to remember the fact that they could perhaps be living with side effects from their cancer or their cancer treatment for longer than ever before as well. So one of the things that really struck me, I was at a survivorship conference down in Boston last year, and one of the points that was made by the director of the Division of Cancer Survivorship of the NCI is that we need to think not just about length of survivorship, but also quality. So when we think about quality of life, health span is really the lifespan of an individual after cancer. So we want them to be as well as possible for as long as possible. It's not just about quantity, it's about quality. So as far as Healthy People 2020, which I'm sure most of you are familiar with, one of the main objectives is to improve both the mental and physical health of cancer survivors. So again, that's something that's well within your scope. And so why are we being successful in increasing the numbers of cancer survivors in this country? Well, it's a couple different reasons. And so a lot of it comes into the diagnostics. You know, we're able to diagnose cancer sooner and more accurately than ever before because of technological advances. We're able to treat it more effectively. And so when we think about all of the things that we do to treat cancer, that efficacy of those treatments has improved over time. We're following up our patients better. So we're looking for recurrences. We're monitoring patients better. And then when we think about the demographic shifts, this country is facing, although some people don't like the term, the silver tsunami of the geriatric population is really changing the age of our overall patient demographic. And then the obesity epidemic is another thing we need to consider. Many cancers are actually correlated with overweight or obese. So we know that that is also an epidemic that this country is facing. So even though it's not necessarily a higher incidence of cancer, you've got an older patient population who has, you know, other issues that can contribute to cancer. So when we think about cancer survivorship continuum of care and sort of the lifespan, how many of you intend to work or hope to work with pediatrics or adolescents? Okay, so when we think about the subset of children who are diagnosed with cancer, that is a unique patient population in and of itself. So usually you're in a larger academic tertiary care center and you are seeing that rarer subset of pediatric cases of cancer. AYA is a new distinct group of cancer survivors as well, the adolescent young adults, ranging between 15 and 34. And so adult, I believe they call adults, I guess it's all relative as to when you become an adult, but 35 to 64 is sort of that typical adult range. So most cancer centers are treating adult cancer survivors. And then geriatric oncology is now its own specialty as well. So when we think about the percentage, according to the NCI, 61% of cancer survivors are older than age 65, and estimates by 2040 are that it'll be 73%. So when we say cancer is traditionally a disease of aging, it's about acquired genetic mutations and things that occur over time. Certainly not all cancers, but the majority. So what does that look like? When you see the purple portion of the pie, that's where the preponderance of the cancer survivors are in that age range. So as far as the continuum is concerned, there's lots of public health initiatives that are looking for preventative strategies, community collaborations to try to improve the health of the community and reduce the risk of cancer, things like smoking cessation programs and other initiatives, physical activity programs. We obviously need to detect cancer, but it's really this continuum from the point of diagnosis, as I mentioned earlier, through the remainder of life. This is where we as healthcare clinicians are most frequently going to encounter our cancer survivors, and that we can make the biggest impact, but certainly public health is another important entity in the community. And when we think about the cancer survivor challenges, I'm not going to read this list to you, you can take a look at it, and it is not an exhaustive list. There are a lot of side effects that our cancer survivors can experience, and they're not just associated with the cancer itself, it's really the cancer treatment, unfortunately, that can result in a lot of these symptoms. When we talk specifically about breast cancer, when we're dealing with certain types of chemotherapies, they can be challenging as far as the heart is concerned. They can cause cardiac toxicity. They can cause chemotherapy-induced peripheral neuropathy. Some surgical procedures, radiation procedures can result in lymphedema. And so there are lots of things that, again, are within your wheelhouse and your ability to help these patients. So don't underestimate your ability to do that. So when can we do that? If we are lucky, and what I was very fortunate to work with Dr. Palladino on was our multidisciplinary breast cancer clinic. I got to meet our breast cancer survivors before they ever had surgery. So they had a biopsy-proven breast cancer, but they had not had surgery yet. So that is a very early and very fortunate time to be able to introduce yourself to a cancer survivor and be there from that point forward. So we obviously see people through active treatment, whether it be chemotherapy, maybe with radiation, maybe concurrently with radiation. And then some patients go on maintenance care. If they're in palliative circumstances where they need to take a medication for the duration of their life, they may be on a maintenance regimen, but there's also post-care and remission, when somebody can be able to say, okay, I'm done. You know, I am done with treatment and I am sort of moving on with my life. And then palliative care is a separate specialty in and of itself. We need to be able to control symptoms, help people stay as functional and as active as possible for the remainder of life. So one of the ways that we do this, and there are lots of major entities out there that now recommend that we use survivorship care plans. I will tell you that this is not yet operationalized in a perfect system at every cancer center in every region of the country. But what we are striving for, and what the guidelines are telling us we should do, is provide a survivorship care plan that includes two things: a treatment summary and a follow-up care plan. If a patient moves somewhere and they get a new doctor, they need to be able to say, this is the treatment that I had, this is where I had my radiation, these are the types of chemotherapies that I had. So a lot of patients, they just don't know, they know their adriamycin was red, they know they had chemo for 4 cycles, and some of that information is sort of lost. But if we have a treatment summary, we can actually delineate that to them. And then really, what are the follow-up recommendations? How can we keep them well, keep them physically active, talk about things like nutrition, psychosocial and emotional support and counseling. So there's lots of things we need to be able to do. And again, part of the point is, how are we looking at them for follow-up? You know, if we give a breast cancer survivor an aromatase inhibitor, we are putting them at risk for bone loss. So we need to be diligent about that. If we gave them one of those chemos that we know can cause cardiac issues, it's on us to recommend that they get proper follow-up for that. So when we think about the team, it's a tremendous team, and I've been very fortunate to work with pretty much every list of disciplines that you see there. And so from a standpoint of rehab, it's not just PT, OT, and speech. There's exercise specialists, there's yoga practitioners. We also, clearly nurses can be some of your best mentors, so make friends with your nurses in the different portions of the cancer center because they know a lot. Pharmacists are also a wealth of information. You need to understand the medications that your patient is having. Radiation therapists are going to be able to tell you about the treatments that are being done. Obviously, you need your physician champions. We were tremendously fortunate to get Dr. Palladino to come to Exeter for the purpose of starting our multidisciplinary breast clinic. So I didn't have to convince her that rehab was a good thing for breast cancer survivors because she was already there. But your mid-level providers are going to be a tremendous resource for you for referrals. So your nurse practitioners, your PAs, certainly are the gatekeepers a lot of times to making sure they're monitoring symptoms and getting patients the referrals that they need when they need it. Certainly other allied health clinicians, your dietitians, social workers are invaluable. Patient navigators are now a critical component in cancer care. And then integrative oncology and wellness. There are lots of people that can help you with your cancer survivors' recovery, and it's just a matter of making sure that you know what resources are available, and remember, it takes a village. You cannot do this alone. You need a team approach for that. And then really, the cancer survivor and their caregiver is just as integral in that team as anyone else, so don't forget that. And I put this here, two things. If you wear a Christmas sweater on the day that the photographer comes, that Christmas sweater will haunt you for years to come if it gets out there. But anyway, I wanted to just give a shout out to all the wonderful people I worked with at Exeter, because it's the therapists, the social workers, the personal trainers, the yoga instructors, the artists, the art therapists that really made our program a success. So when you think about your opportunities and where you might be able to sort of get involved when you are out there in your early career and you are getting integrated into a organization, You have to think about what is it that they're doing there. And you're not going to have all of these types of clinics in every single facility. You might just have a breast cancer clinic, or they might just have a chest clinic. You have to sort of see where it is that you can get a seat at the table, because if you don't ask, the invitation might not just come naturally. You might have to ask. And then think about other things that already exist. Every community cancer center has a weekly tumor board. They usually have interprofessional conferences. They've got a cancer committee. So again, think about where it is that you might be able to get involved, and definitely do that. I'll make sure this list gets provided to you, but I just wanted to mention there are major national entities now that have survivorship guidelines. So this is not our opinion anymore. This should be standard of care. And so one of the really good ones, ASCO, has a survivorship care plan example that even if your patient is not being treated at a cancer center that has a formal way of doing that, you can at least give them that document and say, ask these questions and have them fill this in for you, because this is your treatment summary. So you can be the one to advocate for that. And then last but not least, I highly suggest, as Ali and Dr. Palladino have, being involved in your community, where you work and where you choose to start your career or have your experience. You are a member of that community. You're a member of that cancer community. So you need to be part of that and be part of the outreach, part of the awareness, part of the prevention and education of the community. So again, don't underestimate your role and opportunity to do that, because it's a substantial opportunity. So I am going to stop there and let Dr. Palladino talk.
Good afternoon. So Dr. Literini is a hard act to follow, but maybe if I say a prayer, we're in the church, you know. Maybe that would work. I need a prayer because she's given me a task that only a miracle worker could perform, and that's to teach you all about breast cancer in about 10 minutes. So the surgery, the medical oncology, the radiation oncology, the palliative care, we're going to whiz through all of that. Breast cancer is a heterogeneous disease. You might think, is there enough with breast that you could be a breast specialist? But indeed it is. It's a heterogeneous disease that's different in every person. There's about 12 different kinds of breast cancer, and then in between that, there is some breast cancer that's hormone sensitive, some that isn't, some that's more sensitive to chemotherapy than others. So each treatment plan has to be individualized for the patient. And that's one of the reasons why we have multidisciplinary clinics, because everybody needs to be on the same page at the same time in putting in their input to come up with a treatment plan for the patient. Oh, hey. So we got it all now. Hi, Allie.
I want to see the presentation.
I can turn you around.
Can you turn me around? I love these beautiful people.
I know.
But I just can't.
So I'm on here now?
Yeah.
Okay. Oh, good.
So I thought I would just start with a few hot topics in breast cancer. And what could be hotter than what some people think is the hottest person in the United States, Angelina Jolie. So I just trying to get your interest. But you may have heard that she had bilateral mastectomies and bilateral salpingo-oophorectomies because she was a gene carrier. So hereditary breast and ovarian syndrome is a well-known syndrome where women are at increased risk, not for just breast cancer, but for ovarian cancer. And we're going to talk a little bit about who those women are and how we want to identify them and make sure they're tested for those genes. These are just some of the risk factors for breast cancer. How do you get breast cancer? We're going to talk a little bit in a minute about the different types of mechanisms for getting breast cancer, but certainly the gene mutation confers the highest risk for the development of breast cancer. Previous chest wall irradiation, these are young women who have undergone chest radiation for, say, Hodgkin's disease. That really increases their risk for breast cancer later on, often in their 30s or 40s. Increased breast density, we think, increases risk because dense breast tissues are very active, they're very proliferative. I call them busy breasts. Sometimes typical cells will undergo change to atypia, which is another risk factor for the development of breast cancer. Nulliparity, never being pregnant, or a late first birth increases the risk a little bit, as does the length of the menstrual history, so early menarche, late menopause. Postmenopausal obesity is important for us to think about because there's a real peak for breast cancer in the sporadic incidence of breast cancer around the age of 70. Most breast cancers are estrogen-driven. Okay, so breast cancer is either like estrogen or they're not affected by estrogen. The majority are estrogen-driven. So where do postmenopausal women get estrogen? Body fat is one of the main places. Estrogen is stored in body fat. The higher your body fat, the higher your estrogen. So we want to make a real effort to try to get these women to lower their weight. These are just some figures as to the incidences by age of women who are gene carriers. But what's important to note that there's 3 types of presentations of breast cancer. The most common is what we call sporadic. That means it just happens. And this is something that I think is important for you to know because a lot of people say, well, I don't have it in my family history. I don't have to worry about it. I don't have to get mammograms. Most women who are newly diagnosed with breast cancer have no family history of breast cancer. Important to know. So sporadic is number 1. Familial is number 2. That means it runs in the family, but maybe you don't carry the gene. A lot of families have a lot of breast cancer. I have 2 identical twin sisters with breast cancer. I also have family history of ovarian cancer. We're not gene carriers. It's a family problem. And then the final is the hereditary, the BRCA gene carriers, and that's responsible for only 10 to 15% of all breast cancers. We're going to talk about who are the women that we have to worry about might be gene carriers. So Ashkenazi Jewish women have a really high risk for carrying the BRCA gene. I thought this was kind of a startling picture. It was from one of my biggest sources of medical knowledge, the New York Times. And as you can see, I know Allie's laughing. So this patient had one of the main ways we treat breast cancer surgically, a lumpectomy. You see the incision above her nipple. And then if you look in her armpit, there's a little incision. That was for what we call a sentinel node biopsy, where we sample the lymph nodes in the armpit to make sure they're not involved with the cancer, because that will really affect the treatment, especially whether or not they need chemotherapy. Sentinel node biopsy has been a real boon for the surgical treatment of breast cancer because in the old days we used to always do axillary dissections. So you know there's 3 levels of nodes in the axilla. In the real old days, we would clear out all of those nodes and big risk for lymphedema. So especially if the patients are going to need radiation, if you combine radiation with an axillary dissection, the risk for lymphedema is really raised. It's also higher in obese women. So this operation, although you still can get lymphedema, it's much less common. These are the people that we want to screen for hereditary breast cancer. Anyone who's had ovarian cancer, breast cancer diagnosed less than 50, bilateral breast cancers, a history in the family of a male breast cancer. We test all triple-negative women. Triple-negative means estrogen receptor negative, progesterone receptor negative, and HER2/neu negative. If they're negative in all those categories, they have a high risk for carrying the gene. And then there are other cancers associated with that gene, including pancreatic and melanoma. So not all women do go the Angelina Jolie way. We do recommend that tubes and ovaries be removed once you're finished childbearing. But the breasts don't necessarily have to be removed because we have a really good screen for breast cancer, and that's breast MRI. So women who are gene carriers who opt not to have their breasts removed, like that picture you saw, that woman was a gene carrier, but she opted for lumpectomy. She should have an MRI of her breasts every year, along with mammography. Mammography is still the gold standard. You can see things on a mammogram like calcifications that could be an early breast cancer that may not show up on MRI. But we don't have a good screen for ovarian cancer. So those women should have their breasts removed, their ovaries and tubes removed. If they're saving their breasts, they should think about chemo prevention, which is anti-estrogen, okay? So most cancers are estrogen-loving. We put them on a drug called tamoxifen, which lowers their estrogen. So I want to talk, I'm a surgeon. We love to talk about surgery, and Amy said you would like pictures. So just when you start to go down, I'm going to rev you back up. When I was a student, radical mastectomy was the way we treated breast cancer. And I mean radical. We would take skin, we would have to put skin grafts on them, we'd do a full axillary dissection. And I thought back then, someday we won't be doing this operation anymore. And I was right, but we're still doing mastectomies. In fact, the incidence of mastectomy is increasing in this country, and we're going to talk a little bit about that. But we went from that to lumpectomy and to sentinel node biopsy. This patient has had bilateral mastectomies. Not so shabby, huh? It's beautiful. I'm still amazed when I look at these women post-operatively. After some of the things I'm going to show you, this is a patient has had bilateral nipple-sparing mastectomies with bilateral reconstructions. So we put the incision under the breast in what's called the inframammary fold. We flap that envelope, skin envelope, all the way up. We use lighted retractors, and we get all that breast tissue out. The boundaries of the breast are the clavicle, inframammary fold, sternum, and the latissimus. It's not an easy operation, but this is the result. Compare that to this. This is what I used to do when I was a resident. Patients had her pectoralis major and minor removed. She's had a skin graft put there, and she's a real risk for lymphedema and nerve injury. This is a radical mastectomy where we leave the pectoralis minor. The brown staining is from radiation. This is a modified radical mastectomy, also not very good cosmetically. This is a patient who's had a skin-sparing mastectomy with implant, and she has had her nipples reconstructed and tattooed. None of those are as good as this. So nipple-sparing mastectomies have been found to be safe. You have to be careful under the nipple that you're sure you core out all the ductal tissue. You don't want to do it if the patient has ductal carcinoma in situ right close to the nipple or cancer right close to the nipple. If they're too ptotic, if their breasts are too low and too big, it's difficult to maintain the blood supply of the nipple. It can be worth a try. The worst thing is the nipple could die and then have to be reconstructed. One of the newer things we've been doing with these operations is what's called an alloderm sling. So that piece of skin at the bottom is called alloderm. It's cadaver skin. So here's a shout out for donating your bodies and your skin. Your skin could end up in one of these reconstructions. This forms a sling for the implant, because the pec major gets very thin down there, especially at the level of the sternum. We want to put the implant under the pec major, so we don't always have enough muscle to cover it. But this makes a nice sling to cover the implant and keeps the implant where it belongs. So the next treatment I want to talk about is lumpectomy and sentinel node biopsy. There's all different ways to do this. This is a bad one. This patient came to us and asked, was there anything we could do about this? This was a poorly planned procedure. She ended up after radiation with not just a shrunken breast on that side, but retraction. There's better ways to do it. This patient had a lumpectomy with what's called an oncoplastic flap. So if I'm worried about that my lumpectomy might cause too much tissue loss, I ask the plastic surgeon to scrub with me. She moves tissue around, fills up the gap, and that's one of the results. This lady, this is a problem because you've got giant breasts on both sides. So for her, we designed her lumpectomy with bilateral breast reductions. So insurance pays for this. They still have their radiation afterwards, but cosmetically, they have a good result. It's a bummer having breast cancer. The least we can do is try to have them have a decent cosmetic result. So that's surgery of the breast. Any questions? So we're going to go on to radiation. So we use radiation in breast cancer. If we do a lumpectomy, we recommend radiation therapy for the patient because it decreases the risk for recurrence of the breast cancer. If we do mastectomy and the patient has nodal involvement, we also recommend post-mastectomy radiation. There are increased survival rates with that. We don't always recommend radiation if we have an 85-year-old with a tiny little estrogen receptor positive tumor. We might just take it out and put her on an anti-estrogen. But this is one of the newer techniques. Whole breast radiation, which is the first picture, is usually 6 weeks of treatment, 5 days a week. It's quick once you get in there, you're in and out in 15 minutes, but it's 6 weeks, 5 days a week. And then we have accelerated partial breast irradiation called the mammocyte, where a balloon catheter is put into where the lumpectomy was, and the patients have 5 days of treatment twice a day. And now the last one is called intraoperative radiation therapy. This is what we do at Exeter. It's not for everybody. It's got to be good prognosis patients with not huge lesions that are estrogen receptor positive, progesterone receptor positive, and are in a place in the breast where we can put a balloon catheter in and still have a skin bridge of about 1 centimeter, because if we don't have that skin bridge, when we deliver the radiation, you can burn the skin. When breast cancer recurs after lumpectomy, it almost always comes back right where the cancer was. So people say, well, why are we treating the whole breast? Why don't we just treat where the lump was? And that's how these partial breast techniques have evolved. This is actually one of our operating rooms. So I do the lumpectomy, create the cavity, then we have a different size balloons that we measure the specimen, see how many grams it is, pick the correct balloon size. We put the balloon in the cavity, close up the incision. The radiation oncologist comes up and presses the button. I always tease, this is Dr. Prue, our radiation oncologist. I always tease him like, all right, I've been here for 2 hours doing this. You come in and press the button. I got him a little Playmobil gym for his office so he can work out. So anyway, good results with intraoperative radiation therapy. We've done about 120 now. We've had 2 recurrences, and those were both in women who refused to take their anti-estrogen medication. I think that the anti-estrogen medication is the most important piece of the puzzle. That's what prevents breast cancer. That's what prevents it from coming back. And there have been studies to prove this. The P1 trial took women who were at high risk for breast cancer. They gave half of them tamoxifen, half of them placebo. The tamoxifen group, the breast cancer rate decreased by 50%. It's huge. So mastectomy rates are increasing. One of the reasons is people say, well, Angelina Jolie had it. The other reason is MRI, because MRI is finding a lot of things, sometimes on the other breast, and women get freaked out and say, take them both off, which is a very common response, especially initially when they get the diagnosis. But after you talk to them a while and educate them, they usually come around. We really push for breast preservation because the survival rates in stage 1 and 2 breast cancer are the same whether you have lumpectomy and radiation or whether you have mastectomy. So if you can preserve the breasts, why not? Some women think taking their breasts off is going to increase their survival rate, and that's why they ask for it. So I'm always clear to ask them, why do you want that procedure? And this is just a picture of an MRI to show you that it really does a good job at finding breast cancer. You could see there's something wrong there, right? It lights up like a balloon. So we're going to just segue. I didn't talk about chemo, but we can have Allie talk about that. No, we'll talk about chemotherapy when we talk with Allie, but a plug for the multidisciplinary approach to breast cancer. This is Dr. Prue, the radiation doctor. We've got an oncology nurse in the back, a research nurse. That's the plastic surgeon. You might know that woman in the front. She was our patient navigator at the time, but we also have physical therapists on this team. They come to our multidisciplinary meetings. We identify patients who we think should have impedance testing of their arm prior to surgery, and then they're tested again after to look for changes in pressure that might indicate early onset of lymphedema. The guy in the right-hand corner is a radiologist. So before the patients come in, the radiologist, med-onc, rad-onc, surgeon, social worker, navigator, physical therapist, social worker, I said, nursing, we all get together, we look at the slides, we look at all the images, we come up with a treatment plan. And then the patients are examined by the med-onc and rad-onc, and then we have what we call a wrap-up session with them at the end. That's me when I didn't have gray hair. It was like a year ago. But yeah, this is a very important piece of the puzzle. Sometimes if we have a lot of patients, we've been running 4 every Monday now, it's hard to get the team back together. But to me, this is the most important part of the clinic. When the patient sees that we're all there with them at the same time, on the same page. What's in the future? Someday you won't need breast surgeons. We'll just be sticking catheters in there and blasting these tumors away with lasers and cryotherapy. And there'll be different ways to identify the positive sentinel nodes so we don't have to worry about lymphedema anymore. That's just an example of a way to cryoablate a tumor. So I think that's all I was going to say for now.
So Allie, thank you so much for being here. Obviously, Diane and I wish we could give you a hug. We're happy you're in the Caribbean safely. And so we wanted you to go ahead and tell your story. The students would love to hear it.
Okay, well, hello everybody. Thank you for coming. Thank you for having me. I just have one question for Diane before we start. Is why do my boobs not look that good?
She doesn't have an answer for you. They look better, that's why.
I wasn't sure if she responded because
She
I can't
didn't.
hear.
Can you hear me?
I can hear you now.
Your boobs look much better than that. And I love how your hair's blowing. I mean, yeah. Okay, go ahead.
I would show you, but anyway.
She would, believe me. She totally would.
Okay, so I just turned 50 this year. I had breast cancer. I was in 2004. I was in bed reading, found a lump under my right breast or under my right armpit. I thought it felt like a little pebble. I said to my husband, or my boyfriend at the time, I said, "Oh my God, feel this. What do you think this is?" And he's like, "I don't know, but you should get it checked out." So I went to get it checked out. Initially, they said, "Let's just check it out later. Let's check it out, a month later." My boyfriend at the time knew that I was a total spaz and wouldn't be able to rest. So he went back to the doctor and said, "She can't wait. Can we just do something just to make sure?" So we went right to an ultrasound, and we found that indeed there was a spot that there was a little suspicious. What was wonderful about that, even though it was very scary, was that at the time, the doctor came in and said to me, the radiation doctor came in, or radiologist came in and said, this does look a little suspicious. What I'd like to do right now is get a mammogram. And he literally handed me off to a patient navigator who then took me up to get a mammogram. I got a mammogram. Right after the mammogram, they said, "You know what? We can wait and make an appointment with a doctor or surgeon for you, or you can go see this woman named Diane Palladino, and she can take a biopsy right now." So, if something happens to me, I want speed, and not a lot of people are like that. So, went up to see Diane, and nice, we hit it off. We're both from Philly, so we had a nice little talk. She's like, "I'm going to take a biopsy. We're going to check this out. We're going to find out what's going on." Unfortunately, while she was doing the biopsy, my boyfriend was at the door knocking, like wanting to come in, wanting to know what's going on. But she handled him really well. Anyway, so I waited a week or 5 days. Diane ended up pulling me into the office, telling me that I had, I think it was stage, I don't even remember. Diane, what was it? Stage one? Stage one. It was a mass in the outer quadrant of my right breast. Was about 1.5 centimeters. I'm cheating a little because I have some notes here. It was ER positive, and it was HER2 negative. And they did a staging workup, and there was no evidence of metastatic disease. So a couple things were happening at that point in my life. So I was in a long-term relationship with my now husband, Lawrence. I wanted to have children. I wanted to get married. It was just everything happens at one time kind of feeling. So right when I found out, I went and had very quick in vitro, and I ended up preserving 8 embryos. And right around then, Lawrence proposed to me. And so the whole plan was to get rid of this cancer and get married the next year. So wait, I'm going to go up on my notes for a second. It's been a while, so I have to look at my notes. In March of 2005, Diane did a lumpectomy on me with a sentinel node lymph node biopsy. After that, I started chemo. I did ACT. And then I did 8 weeks of radiation right in that area. Is there something else? I feel like I'm missing something. You two? No? What was that?
You had a discussion with Dr. Hammond when you were done with your radiation?
Oh, okay. So then after I was done my radiation, Dr. Hammond, who was my oncologist at the time, had brought me to the office and he said, you know, your next steps are tamoxifen. And me, being me, and wanting to have a child, I wanted to get married, I wanted to have a child. I was like, no, I'm never going to get this again. It's never going to happen. I'm not going to do tamoxifen. I'm going to try to start having a baby. I'm going to get married and have a baby. And so that's my story. I did get married to Lawrence in 2006. And I did deliver my baby Lily in 2007. So I guess for you guys, thinking about what I kind of went through, the very short version, what would you say as for suggestions for survivorship? What would you give me? What kind of suggestions would you have given me? Anyone? Bueller?
I just would like to add that a little piece she left out, which will give you some insight into who she is. When I sat her and Lawrence down and gave her her diagnosis, she looked at me and she said, "This must be so hard for you." She blew me away. I mean, I had been doing the job for 30 years at that point. No one had ever said that to me. So I can tell you what I suggested, that she take tamoxifen. I mean, we had some battles about it, but I lost.
She lost. She did lose. But you know, it was because, and I think this is an interesting thing for all you guys, is that you know, you really just have to take into account what your patients are going through in life, you know. And I guess my theory was I did everything my oncologist told me to do. I did everything my surgeon told me to do. I did everything my radiation oncologist told me to do. But that was the one thing I was totally done. And like I said, I wanted to have a baby. And luckily I did. Mm-hmm. So do you guys want to, I can't see Amy and.
Hi.
I can't get my visual cues like when I'm there.
So no recommendations for Allie at this point. She's just starting survivorship. She's a young adult.
Hello. Thank you very much for sharing your story. My name's Hattie, and I'm an occupational therapy student. So we just learned about some side effects of radiation and with the skin and with your arm there, and you also have a new baby. So we would just want to make sure that you could handle the symptoms from the radiation and sort of gain your strength, gain everything that you're able to do, as well as take care of your baby and sort of help with the symptoms after your chemotherapy and radiation, and just make sure that you're able to do everything you want to do and live a balanced lifestyle.
Thank you very much.
This was horrible, but I had a hard time hearing her.
She was most interested in making sure that you had recovered from your surgery and your radiation so that you could handle being a new mother with a new baby and the lifting and all the things that you needed to do with baby Lily.
So let me just make sure I heard that. you want to know if somebody talked to me about the stresses of motherhood, in other words?
Sort of. Yeah, making sure, right. Well, so, and I think the good thing for you is that your recovery from your initial treatment was really excellent. So when you were seeing Dr. Hammond, it was, over the years after you had Lily, you were sort of like, I'm in for my follow-up appointments and I'm out of here. And you didn't have a lot of symptoms at that point, correct?
No, no. But
Right.
I think I was pretty good with following all my orders that I got from both Dr. Hammond and Dr. Palladino.
Right.
And I did have, I actually did have a very good support system. I had Lawrence and I had my mom, and I guess I was very stubborn too.
Not you.
To be fair, Dr. Hammond, after I had Lily in July of 2007, Dr. Hammond did bring up tamoxifen again, the idea of taking tamoxifen again, but I said no because I had read, because I'm a doctor, but I had read online that that tamoxifen after a certain amount of time is not as viable, right? And I guess I was partially right, but I'm not a doctor, and I do this to myself a lot. I pretend I am, but I didn't go back. I was like, I'm done. I'm not going to do it anymore. I'm done.
So do you want to tell us? You want to fast forward to the your new golf clubs that you got?
Yeah. And I don't know why. I'm having a hard time hearing you, Amy, and people, so I don't know
If I'm closer to the mic, is it better?
No, it's
Worse. I don't know how to fix that, Chris Hall.
Well, I'll talk.
Okay.
Maybe you can. So then let's fast forward. It was 2011. I was not really playing golf, but at a driving range with my husband, my then husband, yes. And then I took a swing and I heard this bizarre crack. And I was like, oh man, I must have just hurt something there. That swing was, huge. And I hobbled around a little bit. I was a new mom, right? So let's see, Lily was 4 years old by then. I was working, I was a new mom, I was just moving and grooving. So I went home and I thought, God, you know what? I'll just take some pain meds for that and self-medicate myself and we'll see what happens. So I was in pain for a long time. I, again, am stubborn. I waited 10 weeks before I went to see my doctor. And that was my GP that I went to see. Again, I played doctor, and he said, well, do you want to get some x-rays of this? And I was like, no, just give me some physical therapy. I'll be fine. I've tweaked my back before, just give me some physical therapy and I'll be great, and let's just, don't give me anything else. Again, I was taking like Advil, I had some Dilaudid on the side. I mean, it's just... Again, I should have actually went to school instead of just pretending that I was a doctor. Anyway, so in those next 8 weeks, I had physical therapists working on me. I was, again, self-medicating. Finally, I went to a chiropractor who was literally like laying on top of me, right? Finally, after 3 weeks with him, he said to me, okay, I got to see your x-rays. Can you have Exeter Hospital send over your x-rays? I was like, no, so I never got any. So that was a Monday, that was a Friday. On a Monday, or that Friday, I went and asked to get x-rays done. On a Monday, I got a call from my, again, GP, and he said, I'm sorry to tell you this, Allison, but you have metastatic breast cancer to the spine. So, of course, me at the time, I was like, what the hell is metastatic breast cancer? And I got online immediately, which was really the wrong thing to do. Then I went, I saw these guys moved so fast. That was a Monday. Dr. Hammond and Dr. Palladino called me, and Amy called me that next day. By Wednesday, I was in their office having a multidisciplinary clinic. I remember not really understanding what was happening to me. I'm sorry, I think on that Tuesday I actually had an MRI, like a full body MRI. And I remember really not understanding what was happening to me. I was sitting on this table with the gray-haired lady who wasn't gray at the time, and Amy and Dr. Hammond and Lawrence. And Dr. Hammond was like, okay, so this is what we're going to do. We're going to give you a bunch of steroids, because at that time I was coughing and losing feeling in my legs. Didn't realize it, just didn't know what was going on, you know. And so he immediately put me on a bunch of, I forgot what the steroid was. And I, like from my back of my neck to the bottom of my spine, because what they found out was I had mets in all throughout my spine, in my ribs, on my femur, in my neck, just sort of all over the place. And I remember the thing that I remember the most from that conversation was after Dr. Hammond said to me, hey, we're going to go right into radiation. It's going to be 5 weeks. I was like, okay. Like, I just was so stunned about what was happening that I just went, okay. And I think Dr. Palladino said, well, do you have any questions? And I was like, nope. And my husband said, well, I have tons of questions, or whatever he said. I don't remember what Amy said, but he got up and walked out because he was so upset, because I think he probably did a lot more reading than I did. So he got up, Amy followed him out the door, and I looked at Dr. Palladino and I looked at Dr. Hammond, and I said, well, wait a minute, what's the big deal here? I'm not going to die, am I? And I remember Dr. Palladino sort of looking down, and I thought, oh, that's not a good sign. And I remember Dr. Hammond, he kind of looked at me, and I said, well, tell me what I've got, like, give me the number. And he said, well, and you know, I pestered him. To be fair, I pestered him all the time. I don't even believe that he agreed to be my doctor after 2005. And I remember he said to me, you have about 31 months. And I said, 31 months? And he said, the average patient has 31 months. And I said, well, I'm not the average patient. And I remember getting up, and so that was very hard. I'm sure you guys want to add stuff there. You too. I can see you now.
Well, I remember very vividly Dr. Hammond, when you said, am I going to die? His response was, we're all going to die. And I thought,
Say that.
I don't think that's the answer she needs. And I subsequently, in my hospice and palliative care work, realized that that probably wasn't the best answer. But what she has shown us is something we know about breast cancer metastatic to the bone, that there are many ways to treat it, and that the prognosis isn't as serious as it would be if she had had spread to a major organ like liver, lung, brain. So bone mets in breast cancer can be treated, obviously, for years and years. And Allie's lucky that her tumor was estrogen loving, because there's a whole bag of anti-estrogen therapies that can be used. When one stops working, you open the bag and take out a different one?
So I want to ask the group, as far as, and just to get you to tell us a little bit more about the clinical decision-making of the practitioners that you were seeing at the time, Allie. Can you tell us a little bit more about the physical therapy that you had for those 8 weeks?
Yes, so what I did was, the physical therapy that I had before I was diagnosed.
Right.
Okay, so again, I went into physical therapy saying that I hurt my back. I told them how I hurt my back. So what they did was they did massage, they did heat, they did cold, they had me doing all sorts of exercises at home. They did electric stim on me. They had me, just without asking me really, without delving really deeply into my past. So I did a lot of that, or what they asked me to do, and in hindsight, when I went to, I guess I'm really lucky because my chiropractor was putting all this pressure on my back. It could have gone south really fast. So.
Well, and I just want to clarify from a medical diagnosis perspective that you actually were experiencing spinal cord compression from the metastasis to the T-spine at that point, and that is considered a cancer-related emergency. And so one of the documents that was shared with the group was about what cancer-related emergencies look like and what red flags look like in a cancer survivor. So that's one of the big lessons that you have been so gracious to teach all of our students over the years, is that when someone seemingly very healthy and vibrant walks into your outpatient clinic, you cannot be confused by the fact that they bring with them a past medical history that needs some serious attention. So it is on you as the practitioner to take that history and to make sure that you do your due diligence about the appropriate follow-up. And so I think that's the thing that, in hindsight, I think we all wish there would have been a faster discovery and, potentially no high thrust manipulation of that spot either, because you are correct, that could have ended up in paralysis. And so these are the sorts of things that we hope that this group here with us today takes with them as a remembrance of this conversation, and something that, again, is a potentially avoidable situation for you as practitioners going forward when you take that that history that would have revealed that perhaps some other things could have been done prior to initiating treatment. So, as far as now is concerned, Allie, first of all, you look fabulous, and obviously you are living your life to the absolute fullest. How old is Lily now? 9?
Lily's 9.
Wow. So, and she's there with you. Is she at the beach?
She's at the beach.
Of course she is. I figured she was. But is there something that, well, how about this? I'm going to open it up to questions, but I want to close with you to have some final words for us, okay? So are there any questions from the audience as far as Allie is concerned?
First off, thank you for sharing your story. So I'm a PA student here. My name is Devin. What I wanted to know was, what were some of the things that the practitioners said to you throughout your treatment that gave you rays of hope to continue on? Because obviously you have a very bright spirit, and you have a very enlightening story for all of us to learn from. So what did they tell you? What were some golden moments that you remember that made it much easier to go through treatment?
Okay, so Amy, I just need you to repeat it just a little bit. Okay. Well, first of all, I think the key thing for me, both the first time I was diagnosed and the second time, was I had such confidence in my team because they were all around me at the the multidisciplinary clinic, to kind of look at all these people in a room, all there for you, saying, this is what we're going to do for you, and you're going to make it, and this is what's going to happen. Even if somebody says everybody dies, it doesn't matter. You know, it's just to have that constant feeling like they know what's going to happen. And mind you, but again, both my husband and I, very, you know, always asking questions. I mean, I fought him on everything. I was like, I don't need to take this. You know, whatever. But having that sort of group of people around me, I went through a great program that Amy had me do, where I was working out during radiation the whole time. So I would have radiation, and every other day I would go and work out in this program. So it was never about, you have this and, oh, it's the end of the world. No, you have this and damn, we're getting through it. You know, so it was, I really did have a great team. Everybody was really supportive. Everybody, they were right there. I mean, I just felt like I was the only patient. And so if you can do that as a group, if you can make sure that people know that you're there for them, oh my God, you're going to be rock stars.
Hi. I was just curious. We've been learning in class about fatigue that's related to cancer. So I was wondering if you experienced fatigue, and if so, what did you do to help with that?
So I heard the question, something about fatigue.
Yep. Did you have it, and what did you do about it?
Yeah. So yes, I did have fatigue. I was very, well, okay, so to be fair, I was on tons of steroids initially. So the first couple rounds, and my steroid prescription went down little bit by little bit as I went through the radiation. But I did have fatigue, and nobody ever believes, like people, when I say this to them, I'm like, you gotta work out when you're feeling tired, when you're going through radiation. And they're like, no way, I just want to go home and go to bed. And it really helped me. The fatigue, the just getting out and getting moving and getting your body going. I spent a lot of time too in a warm pool. We had a warm pool at Exeter, and I did a whole bunch of exercises in there. So every day I was in the pool, and every other day I was working out. And it just really helped. And I took care of myself. And I had a good, like I said, I had a very good group of people helping me. And so I was eating well. I was getting my exercise. I was getting enough sleep. I didn't feel like it affected my family that much, other than I had a very busy to the hospital and stuff. But that was, yeah, I think it didn't affect me that way. And quite frankly, I'm rather lucky, because a lot of the medications that I'm on, I haven't had very bad side effects. I'm like, I don't have any side effects really. I feel like I have nothing. So I'm very lucky.
Great. And then can I just say that the exercise program that Allie's mentioning, we were doing a research project that we were randomizing our participants with stage 4 cancer to either a cardio regimen or a strength training regimen. And so I can't remember if you were randomized to the strength training arm, I think. And so it is possible to do strength training with an individual who has metastatic cancer to the bone. It just has to clearly be done properly, and you need to know where it is, what type of metastasis it is, and what exercises you're prescribing. But we had some really great results from it, and you kept going after the study was over too. So you had a lot of good motivation as well. So,
Yep.
Go ahead.
Hi, I was wondering if you were working while going through treatment, and I don't know what kind of job you had, if it was physical or not, but also, did you find that your healthcare providers worked around your daily life schedule, and that your treatment plan helped with your daily life schedule?
Were you working?
So you asked, was I working
People
and
work around
how?
your schedule?
Mm-hmm. So yeah, I was working for the first part. So what I did when I was in 2005, when I was first diagnosed, I was working, I would work 1 week, and then the next week I'd go through chemo and take that week off. And I did that on and off for 4 months. And then when it came time for radiation, at that point, I think just with the chemo and radiation, at that point, I just couldn't concentrate enough to work. And so when I was doing radiation, I didn't work. And then this time, I took off while I was doing the radiation, again, just to take care of myself. So they didn't have to do a lot of workarounds for me. But, you know, unfortunately, I do have friends now who are going through similar situations. And I feel like both Exeter and Mass General, that group, they really try to help and, you know, work around, make sure it's a horrible inconvenience. Radiation is, you know, a pain in the ass, and but especially going every day. But they've always been very, very good with trying to help you make it the easiest way possible, you know.
Time for one more question.
Thank you. Hi, I'm Jacob. I'm an OT student, and my question is, how has, you talked a little bit about your friends who are going through a similar situation. How has advocacy played an important part in your recovery as being a survivor? And how is it for you to, this catharsis to talk about your, the breast cancer and everything?
So just, can you repeat that?
How is it that you are able to use advocacy to help you, and you have some other friends that are going through this? Is it cathartic for you to talk about it? How does that work for you?
Yeah, so having breast cancer the first time was definitely scary. It was definitely inconvenient. Like, it was just, and it's funny to say that, right? Like, it was just something that I did not have time for, and I was angry, but I got through it, and again, as you know, I was very stubborn, and then when I got it the second time, I spent a lot of time initially crying in my room, because I thought, okay, this is the end. This is the end. Did I make a mistake? Should I have gone on tamoxifen? Would I not be in this situation? Then I wouldn't have Lily. I mean, you know, your thoughts go back and forth. I took that. I remember walking into Diane's office at one point and saying, what am I going to do? What am I going to do? You know, it's like, and, you know, what's somebody going to say to you? And so she said to me, live every day. And you're right, that's so simple. I just needed somebody who knew their shit to tell me exactly what to do. And I'm sorry, it must be the Bahama breezes that are getting to me that I'm saying these horrible things, these horrible, horrible words. Anyway, then I realized that just telling people, like giving people hope, talking to them about my story, you know, I don't know what my life expects. I don't know. I really don't know. You know, sometimes I think, I tease Dr. Hammond now because, you know, I'm like, hey, I beat your estimate by 12 months, you know. But I really do try to live life as best as possible. I cherish every moment, and I try to help as many people as I can, because I want, you know, cancer, it's taught me a million things, some really great things. So I can't even badmouth it that much, because there's so many great lessons that I've learned. I just think, yes, being able to talk to you and being able to help you understand that, you know, recognize people if they have it, what you can do for them, how to help them. It's great for me. I'm very lucky to be able to talk to you guys. That's it.
I don't know how to finish that any better than that. Any other last minute words other than thank you from the bottom of our heart?
Here's one thing.
Go ahead.
that can you just tell them what Dr. Hammond said to you about ABC, because I think that's important.
I will. So Dr. Hammond, this is one of the first things Dr. Hammond taught me, and what I will tell you too is that your mentors in your career are not necessarily going to be your same discipline. So remember that my first mentor in oncology was a nurse, and then it was a nurse practitioner, then it was an oncologist, then it was a breast surgeon. So you have to reach out and be like a sponge to the people that can teach you things. So Dr. Hammond always thinks in an individual with a history of cancer, ABC, always believe cancer. You have to rule cancer out first before you can go to any other differential diagnoses. So it seems like sort of the extreme end of the spectrum, but it is your primary differential to rule out. So that is ABC. So thank you so much, Allie. Can I call you
Thank
later?
you.
Have a wonderful rest of
Yeah.
your vacation.
Thank you.
Bye.
Bye, guys. Thank you. Good luck.